Welcome, everyone. This is the Society of Thoracic Surgeons Intermacs and Pedimacs monthly user group call. I appreciate everyone that's joining today. I'm first going to go through some just basic housekeeping. Just want to welcome everyone. Then we'll go over, we'll do some introductions of who's on the call today from STS and the Innermax data warehouse. One of the things I did want to mention at the beginning of this call, I know some of y'all have begun receiving integrity checks, some data queries from Janella Miller from the Intermax data warehouse. And so today we're going to go over the implant discharge form and when it should provide some education of when it needs to be completed in some scenarios. So today on the call, you have myself, I'm Catherine Holyfield, the STS National Database Manager for Intermacs and Pedimacs. We have Janella Miller, who's the Intermax Data Warehouse Quality Manager. We have Jeannie Ann Love, who's our Patient Management Director for Intermacs and Pedimacs. I don't believe Nick is joining us today, but we have Ryan, which is our statistician and our reports guru. We have John Pennington, who's the Intermax data warehouse, the senior data manager. And we also have Carol Crone, who's the senior clinical manager of the STS National Database. And we also have joining with us Leanne Jones, who's the STS National Data Manager for General Thoracic Surgery Database and the Congenital Heart Surgery Database. So thank everyone for joining today. So I just wanted to give an update. I know we've been, this is going on the third month of the pandemic. So as many of y'all have noticed, we have updated the COVID-19 data fields on the pre-implant and the follow-up forms and the death form. So I just wanted to briefly go over again. I know there's still some sites, especially with these patients. We're encouraging televisits. You can do the quality of life surveys, may be done over the phone. Some sites prefer to mail them and have the provide a return stamped envelope and have the patient mail on back. Just so you know, if follow-up visits are done outside of the visit window, please enter the last date of the follow-up date visit into the database. So we want to have this data collected. We understand that this is, you know, a very unusual situation. So we do want to still have good quality data captured. And so that's why we're providing a way for you to still provide the data for the follow-ups, even though it may be outside the visit window. And like I had mentioned earlier, the COVID-19 data fields have been added. And we're working on adding those to the live data downloads. I just wanted to provide some resources. You can go to the Innermax webpage, and if you go under the appendices, that's where you'll find the user's guide, the adverse event definitions. We have some training resources, such as we have a PowerPoint, and I'm also, if you would like a recorded training session, I have a voice recorded training session that I've done and recorded, and if you email me directly, I'm happy to send that to you. You may also find resources on the STS website. You can, if you do go to the STS website and click on Intermax, it will take you to the Intermax webpage. And then we have the Intermax FAQ at sts.org. That's where you can email any questions that you may have to that address. You can also email myself directly, or you can email UAB if you have questions regarding reports. They have an Intermax reports email box, and then if you have questions on patient transfers. So for today, it's going to be an open discussion. Please use the Q&A function. We'll answer as many questions as possible, and we encourage your feedback, and we want to hear from all of you. If there are any questions that we need to look into, we will look into it and then get back to you. So I'd mentioned earlier, I know that many people have been receiving the implant, the integrity checks from the data warehouse from Janella Miller. So I thought today this would actually be a really good topic to provide some education with. So the implant discharge form. Janella, would you like to start off and give a brief overview?
Sure. So the implant discharge form, most of you are familiar with, but there has been a little bit of confusion about it. So I just wanted to go over, first of all, when it needs to be completed. So this form is meant to collect data about what happens to the patient during their implant hospital stay. So when they leave the hospital with a device in place, you would complete this form using their discharge date that they left the hospital with the device in place as the discharge date. Also, if they died during the implant hospitalization with the device in place, then you would use their death date as the discharge date, and you would fill out the death form. If they receive an explant for any reason, whether it be their device is turned off, they get a device exchange, or they recover, then you would fill out this form using the explant date as their discharge date. So if you guys have any questions specifically about what needs to happen in this form, we can answer that during this session.
Yes, and so just as a reminder, this form is completed when the patient is still in that hospitalization from receiving their LVAD. And we added some data entry tips. So if a patient's returned to the OR multiple times, let's say for irrigation and debridement, on the implant discharge form, you can mark surgical procedures other, scroll down to the other procedures, and you can check other specify. And then in the text box, let us know how many times the patient went to the OR for a washout and debridement. I think another important point about the implant discharge form is just so you know, if a patient has died or they're transplanted or even explanted for recovery during that LVAD hospitalization, in that course before they're discharged home, if they had one of those outcomes occur, endpoints happen, then you not only have to complete the implant discharge form, but you have to complete the explant form. So if you had a patient that has their LVAD, and let's say they actually received a transplant, a few days later, then not only would you, and they're still in the hospital from that LVAD implanting hospitalization, then you not only would you complete this and choose transplant, but then you also would have to go to the explant form and explant the device. And the explant reason would obviously be a transplant. And just as Janella said, this form is going to be completed if the patient was discharged alive with the device in place and they went home, or if they went to a long-term care facility, or it would also be completed. Let's say that they had an LVAD implanted and it thrombosed really quickly, like within 3 days of being implanted, then you would still complete this form, but you would choose, you would let us know. One of the options would be that they had an LVAD exchange, and then you would complete this form, and then again, you'd have to complete the explant form.
Yes, and in that case, Catherine, they would have a new implant discharge form. Correct. That relates to the hospital days on the next device. So that can get a little bit confusing, but that's how we do it. Is each implant discharge form is per durable device.
Yeah, thanks for pointing that out, Janella. And the implant discharge date's really important. I'm sure Ryan can verify this, because it's where we have the length of stay for our hospital days on this form. And so it's really important because it'll show up on your reports. It impacts your reports for their length of stay days.
And the readmission metric, having the accurate discharge date, sets off the beginning of that measure.
Yeah, would you like to speak on that, Ryan? I couldn't really hear you, I'm sorry.
Oh, sorry, I'll speak up. Yes, having the accurate discharge date for all the patients is incredibly important for any length of stay or readmission measures in the reporting. And I know it's a little counterintuitive that you have to enter it in for all of the different endpoints, but that really helps us, exactly what Janella and Catherine laid out.
Okay. So again, as Janella said, any questions we're happy to answer in the Q&A function. And I'm going to move on to the next slide. We have some implant discharge scenarios that I was speaking about. And I'm happy I can provide these, actually the 2 implant discharge, these slides are actually on the training section on the Intermacs website, and so you can find them there, or I'm happy to provide anyone that would like a copy of these, would like these 2 slides. Again, as we spoke, if they had the LVAD exchange, then you're gonna, it's the scenario that I spoke about earlier. But I'm happy to provide these implant discharge scenarios, this slide, to everyone or to anyone that would like it. As Janella said, it can be confusing because you do have to count up the, if we go back to this slide, the ICU days and then the step-down care, which would also incorporate the regular floor days in that section. So I think now we'll go on to answering to going to the Q&A function. So is there a way for the implant discharge form to appear as a pending form on our dashboard? We receive this question pretty frequently. Actually, I believe now this is in the data quality report. Is that correct, Janella?
No, I don't think that they've added that there yet.
Okay. So I know there were some issues with putting it on the dashboard. I think our programmers are looking into it. John, do you have any updates on that?
I'm not sure if we requested it because of the fact that the implant discharge form wasn't required a long time ago, and there were a lot of that would not be required that on the older implants that would actually show up as past due, and we didn't want all the centers to be hit with a high volume of past due forms when they weren't required at the time.
Right.
So maybe we could consider doing a date, I don't know, like 2019 and on, or 2020 and on, all the implants after that date could show up on the dashboard. I don't know if anybody has any input.
Hey, Janelle. Yeah, I was going to chime in with something kind of similar. I think we had talked before about even doing things after that May 2nd, 2012 date when version 3 went forward. But no, I don't think that there's any tickets in for it now, but we've discussed very recently what was showing in these pending forms. So it is something we've talked about.
Okay. Well, thanks, Sarah, and we'll definitely look into that. I know now at this time, like we've been talking about, that's one of our internal data integrity checks. So any of those that are not completed, Janella will contact the sites. And the next question, is there a way self-reported measures should be recorded from televisits? Blood pressure and weight are reported by some patients. And that's great. Yeah, if they're reported, I'm fine with entering that data. Janella, do you have an opinion on that?
Yeah, I think that's fine since it's a televisit.
Yeah, I think it is. Yeah, that would be great. Okay, the next question. Are there plans to modify the Innermax profile descriptions to address long-term VAD patients who undergo a device exchange? I understand your pain with this. We actually, this is actually one of the topics at AQO last year. I think a lot of it, you know, since the patient's physicalities changed, obviously from when they receive that primary implant to when they get an exchange, I mean, some patients it's not going to be as dire or critical, so they're not going to be a 1 or 2. I think you have to work with your surgeon and, you know, and figure out which profile really best would fit an exchange. I can definitely take this, you know, I know that the task force, this is a topic frequently, and so I can definitely take this back to the Intermax task force and see if we can help provide any more descriptives for that. Speaking of that, I'd mentioned AQO, and I wanted to mention that at the beginning, but I do want to let everyone know that the AQO meeting, it'll be a virtual meeting this year. It'll be the last week of September, and September 29th is going to be the Intermacs and Pedimacs Day. There'll be more information. Obviously, you'll receive more information and more information posted on the STS and Intermax websites. The Intermax and Pedimacs sessions will be from 10 a.m. to 12 p.m. We'll have a break from 12 to 1, and then 1 to 3, and then 4 to 5 will be exhibits. And I can tell you, we want to still have abstracts. So please, for any of y'all that would like, if you've never submitted an abstract, this would be great. It's a great avenue to have your work and the data at your site looked at. There will be a charge because we'll be providing CEUs, but it'll be greatly reduced. And so we don't have a direct cost on that. We don't have a cost yet, but that should be coming. And Carol, if there's anything I left out about AQO, please feel free to add anything.
I think you covered it, Catherine. This is Carol. I think you covered it. Did you talk about the pre-recorded and the live version?
I did not. Some of the sessions will be live and some will be pre-recorded.
Mm-hmm. And if people are not able to join for the whole thing, the whole all the live presentations will be recorded, and we'll be posting everything online for those who paid their participation fees, or for those who paid for the AQO.
Thank you, Carol.
Sure.
The next question is this form required for ACSD patients? It's not the same implant discharge form in ACSD, but I know there is a discharge form.
Yeah, this is Carol. Thanks, Catherine. This is Carol. So this form is just is relevant to the Intermacs and I think Pedimacs databases, right? We don't have something like this for adult cardiac. So if you're entering your FDA-approved VADs into both registries, this would just be applicable. This form that Catherine has is just applicable to those patients entered into the Intermacs, Pedimacs databases.
Thank you, Carol. The next question, do you prefer a wound washout and debridement to be captured on the discharge form instead of creating an AE form and documenting the OR visit as an additional event during the hospital stay?
May I chime in, Catherine?
Yes, please
Okay.
do, Janella.
All right. So if it meets the infection adverse event definition, then we definitely want it to be recorded as an infection. And there is a question on there saying, was surgery an intervention for this AE? So you would mark yes there. So we definitely want it recorded there. But this is just a way to capture if the patient went in multiple times for the same infection that has already been captured as an adverse event, then you can capture it on the implant discharge form under that other surgical procedures, just to, let us know the extent of how many times they actually went back into the OR for that debridement. And in general, if there is another adverse event that is already categorized, we prefer that you use that one instead of the additional adverse event, because that's just a little bit harder to look at. It's just a big miscellaneous category, so it's a little bit harder to analyze that data that is typed in there. But if there is a major additional adverse event that definitely causes a clinical change in the patient's course, like cancer or something like that, for sure, put it in the additional adverse event. Catherine, do you have anything else to add?
No, I agree with that. Thank you, Janella. The next question, have the data integrity checks caught implant discharge forms that were incorrect? I think I have at least one patient whom had an exchange for TAH and transplant all in the same admission, but we only completed a single implant discharge.
I'm not sure if, I think I sent you the ones that were caught in the integrity checks at your site. We have a few different ways that we're checking it. One shows a length of stay that's equal to 0 days. So some of that is correct. If the patient actually had a device exchange the same day that they got the implant, then I would probably not send that question to you if it's entered correctly. I will just let our data team know that that's actually what happened. But if it looks like the wrong date was entered, we're looking right now at implant discharge forms that are not done on patients that do have an outpatient follow-up visit and that they are at least 30 days after their implant date. So those are the queries I've been sending out now. I haven't finished, so some of you may be on here that will still be hearing from me in the next week or so.
Thank you, Janella. The next question, some labs and blood pressure BP have allowable ranges in Intermacs. If we are above or below those ranges, what should we put? Have been putting unknown. I think if first, for some of the labs, if you have a lab that I would put the one, usually, I mean, we want to collect the correct data, first of all. And so, I mean, I think that if you want, Sherry, if you want to send, like, if it's not off by a lot, we can definitely look at our values. I know that we do increase the high ends, and we've worked with the low ends. So if you want to send me just some examples, that would be great, and we can look at it.
Can I make a few comments here, Catherine? This is
Sure.
Ryan.
Yeah,
I think the intention of these ranges is to screen out biologically implausible values. So if you have real values that are you're not able to enter, that's certainly not the intention. So, yeah, Catherine, if we could get examples, that'd be super helpful. Thanks.
Ryan.
thanks, Ryan.
Oh, Ryan, this is Carol, and I don't know the Intermacs ranges all that well, but are there usual high and usual lows, and then high and low? So, you know, the usual high and usual low would be, you know, the usual values of what would be normal within a normal type of range, and then
Right. There's some way that there's like a warning range, and then there's some range that it just won't let you enter it.
Yeah.
I'm not entirely in the loop in how that's been implemented, but I know it's not just one specific. And correct me if I'm wrong, Janella. That's how I'm remembering it.
I don't think there's a warning. I think that either you can enter it or you can't.
Oh.
Yeah.
Oh, okay. I'm getting confused.
There's not a warning.
Database.
Yeah, it's Carol. It's
Okay.
just set values. Like it's just like for creatinine, it would be from, you know, one value, a low end to a high end.
or like really crazy lows and really crazy highs, and it should
Yeah,
never be outside of
yeah.
that.
There's no warning. It just won't allow you to enter it. It'll say like if it's out of the range, you just cannot enter it into the database.
Got it. Okay, thank you.
Yeah, sure. And blood pressure is actually hypertension. The blood pressure, that's actually a triggered event. So those values, we actually went with the ISHLT guidelines for the blood pressure. Blood pressure values. Why is there a 10-day limit on both ICU and intermediate step-down care?
Would you like me to take this, Catherine?
Yeah, go for it.
There's not a set limit. It will not allow you to enter more days than the implant, from the implant date to the discharge date. So if the patient had an explant for transplant, and then it should only allow the implant to the transplant date. And if you try to add more than that in there, then it won't allow you to enter more days than the patient was actually in the hospital on the device. Like say they were in the hospital a month before they got the implant, it starts calculating the hospital days with the implant date. But if you have any problems with that and need me to help you figure it out, you can certainly email me.
Thanks, Janella. Our next question, yes, will you email me the slides? Yes, Stacy, I wrote down your email address and I will email you the slides. What does ST mean? What does ST mean on this screen, and what are in drop-down options for this? ST is simply it's it's like a missing reason. So whatever's going to be in the drop down, it's going to differ throughout the database. I believe for this one, it might be unknown or not done would be your options. But as we mentioned earlier, we really need this data. I mean, if you enter an unknown or a not done, then you're definitely going to be queried for that. But ST itself stands for status, but it's basically a missing reason why that data field, why it hadn't been completed. And why is this grayed out? I'm not for sure what she means, like why it's grayed out. But if you could expand on what you're referring to, that would be great.
Yeah, if we could, you could let us know the actual patient ID number and the field that you're trying to enter it in. We can certainly check into that.
And the next question, is your core group currently active? Yes. And Andrea, I have, we did not meet last month, but we are in a couple of weeks, and I have you on the email list for that. So you would definitely be included in the next meeting. On the DC form, should the total days of inotrope use be total of days after surgery or all days on and off inotropes during the total hospitalization?
That would be after the days that they were on inotropes while they had the implant in place during the implant hospital stay.
Right.
Yeah.
So it'd be from the implant through their discharge through the hospital. Correct. Is that correct, Janella?
Yes, that's correct.
Yeah. Okay. If patient has an infection prior to implant, then ends up with the infection in the surgical site, should this be reported separately? So if the infection was there prior to implant and then it went to the surgical site, yeah, it does need to be, if it occurred after the implant, obviously it did, after the device was implanted, then you would need to document that in the infection AE form. I know there's a section on the pre-implant form where you can document if a patient has an infection, but actually, is that the same? This actually, maybe you probably need to email myself or Janella, because there's other variables that can go into this, like if it was the same bacteria, if it went from one site to another, and so that would probably be the best thing to do.
Yes, I do think it should be documented as a pre-implant infection, and it should also be documented as an infection adverse event, even if they had the bacteria as a pre-existing infection. If it ended up in the surgical site, then we need to document that as an adverse event that occurred post-implant.
Okay. Thanks, Janella.
Sure.
And our next question, and Kelly, I actually thought I'd replied to you this week about this because Janella and I talked about it. Was a decision made as to whether data can be abstracted retrospectively to a follow-up if it is still within the window date range? For example, at the follow-up date being used, the patient was not able to do a 6-minute walk test. However, the visit 2 weeks later within the window, the patient was able to perform. Previously, I was told you can abstract the 6-minute walk into the follow-up, but also during our televisits, the providers are not getting the KCCQ, however, the VAD coordinators are calling. Okay. So, yes, we do have an answer, Kelly, and I will definitely, I wrote it down and I'm going to send it to you. Janella, do you want to go over what we had discussed?
Sure. So the latest date that the patient was seen within the follow-up window, so if they had their 6-minute walk test still within the window but later than their actual visit, if you could use that as the visit date, then that would be great. Of course, we know that during the COVID and the televisits, some of the visits may be outside the window, so just use the latest date in that case. But it's preferable if the tests and everything were done inside of the follow-up window, just use the latest date that the patient was actually seen and tests were done as the visit date, and then that will keep it consistent with how we've done it in the past, going from the visit date to the prior visit date, so that we're not reporting the same information on 2 different follow-ups.
Right. Thank you, Janella. The next question, we had 2 patients who completed the QOL over the phone during televisits, and then on the next in-person visit, we had them complete the trail making. Can we include the trail making data or not? I just want to clarify, since it was done all after all the other data points for that visit. And that's, I think we just spoke to that.
Yes, it could definitely be included. If it was in the follow-up window, if you would use that date as a visit date, and if not, just use the latest date within the follow-up window.
The next question, are you still planning to release a consolidated recent year report that includes both prior and primary VADs in a single report? If so, do you know what quarter you plan to release a consolidated report? I know that we had discussed this, and we are in the process of making some report changes. So I cannot give you a specific quarter of when that will be released, but we're still discussing how to incorporate both the prior and the primary VADs in a single report. And Ryan, do you have anything to add to that?
Right. My intention is to begin building that and finalizing it, starting in June. I don't know if it'll be ready to go live this quarter or not. I can't guarantee that, but we're actively working on it. And so, I can't make promises, but this is one of the next main set of edits that we're going to add to the reports.
Great. And thanks for the edits that you've that were incorporated into the most recent report. I think the sites really appreciated them. Should controller changeouts be captured as an adverse event? It only needs to be captured as an adverse event if it met a device malfunction adverse event.
Correct. We have been asked this question in the past, and we did say it was up to the individual site if they wanted to keep track of those, but the only place, if it doesn't meet the adverse event definition, the device malfunction definition, the only place we have to record that right now is the additional adverse events.
Okay, thanks, Janella.
Sure.
Can the answers that are given live be entered into the Q&A box along with the questions? that would be a little difficult to do at the same time. But if you definitely have any follow-up questions, or if you would like to go over any, feel free to email us. Carol, are you typing or Leanne, do you type any of your questions in the Q&A box?
No,
any of your answers?
No, we don't type them. We provide them live, and then if there's information that we could provide in our training manual for the adult or congenital or general thoracic databases, then we'll do that. But we don't type answers. It's a live Q&A.
It is recorded, right? If folks want to review the live answers from the recording.
Yep, it's recorded and we post it online. Thank you.
Thanks. The next question, for patients that have chronic driveline infections and have repeated admissions, should we be capturing each one of these rehospitalizations? My concern is that if we do enter the primary reason for rehospitalization as infection for each event, it will then appear as new infections. I can tell you, Patricia, if you want to email myself or Janella, we have a chronic driveline infection data entry tip sheet that would help you with this. Janella, if you want to speak about
sure.
You should enter this.
Yes, if the patient's rehospitalized for a chronic infection, you will need to go ahead and enter that rehospitalization. But we do have some criteria. If you want to get in touch with me or Catherine, we can email you how to handle ongoing infections. And that's basically based on if it's new bacteria or if there's any increasing intervention, then we would want you to enter a different infection adverse event. Say the patient was treated with oral antibiotics and then they ended up needing a debridement. Well, you would enter an infection when they needed oral antibiotics, and then when it advanced to them needing to go to surgery, you would go ahead and enter that infection adverse event saying that surgery was an intervention. Or if there's a different bacteria, then you would enter that infection again. But if it's the same one that's being kind of treated the same way, you do need to enter the rehospitalization for the hospital days, but you don't have to enter the adverse event each time. But we can send you our guidelines for that.
Yeah, definitely. Thanks, Janella. And then another request to email slides, and yes, Fatima, I will get those. I will email them to you. If vitals are not being recorded in the telehealth visits, can we enter vitals from a previous in-office visit as long as it is in the follow-up window?
I would say yes.
Yes. I agree with that. I think that's fine. How long out will virtual visits be allowed? 1 month outside the window, or maybe longer? It's really going to depend on, this has many factors, but if you can email me, I will, we're still discussing this because we definitely don't want, as Janelle had mentioned earlier on the call, we don't want data overlapping from one visit to the next. And so it really just depends on what the follow-up, the windows are for those follow-up visits. And I'm in the process of figuring, of looking at those and seeing the last date that would be feasible for that. Janella, do you have anything to add to that?
No, I think that, yeah, I guess just the leadership there will have to decide what's unreasonable.
Right, yeah. The next question, once you submit Intermax forms, can we go back and enter more data that was obtained after shelter in place lifted, even if it is later than a follow-up window?
I would think that would follow the same rules as the televisits during the pandemic time. So I think that would be okay.
Yeah, I agree. That's fine. Because we know, we know it's been a hardship, and I really appreciate all the data managers and everyone really working and trying to get the data, because I know it's just been difficult to get the data, and we've all worked hard to maintain and to improve Intermacs and Pedimacs. So we definitely want the data. And then the next question is, this may be a little off topic. If a patient has a tunneled RVAD and the pump head is changed out for another type of device, but cannulation remains, patient does not go back to OR, should we fill out an explant form for the RVAD and then do a new implant form as if it was a new RVAD? For example, a patient had a Rotaflow RVAD and the VAD itself was changed out for a Centramag in the ICU. Well, I know, Ashley, since I know you're stating that the patient didn't go back to the OR.
I don't know of another way for them to change the device brand without doing an explant and another implant form.
Yeah, that's the big thing, because you are changing, you're going from one device brand to the next, which we need to follow and capture. So I think you still would have to do the explant form. You're right, and go back. Would you post the chronic infection documentation sheet to the website? Yeah, I'll definitely talk to Carol about that, and Janella, and we'll discuss that. Will you please tell me the criteria for the infection rehospitalizations? And thanks, Tracy, I will. And the next question, could you repeat, please? If a device exchange is required, do the explant and then also do a new form for the new device? Yeah, if you're, Cindy, if you're the one that spoke about going from a Rotaflow to a Centramag, even though it was done at the bedside, yes, you would still have to, since it was a device exchange, you still have to complete an explant form, and then you would definitely have to enter that Centramag as a new device. Janella, do you have anything to add to that?
No, typically the bedside changes, you don't have to do that unless it is like a device brand change, or it meets, a device malfunction or something like that. Sure.
So Cindy, basically, if it was just they were just exchanging the Rotaflow to another Rotaflow, you wouldn't have to go and you could document it on the follow-up form. You wouldn't have to do it on do the explant form. But again, since you are going to a new device, you will have to go through the explant form like you were doing a regular device exchange that a patient went to the OR for. And then someone asked if the tip sheets can be emailed out to all the participants who attended today's meeting. Thanks. Yeah, I think we have those. I think we have those emails addresses, everyone's email addresses who logged on. So that shouldn't be a problem.
Yeah, we could probably send them out to everybody in the Intermacs database, Catherine.
Thanks, Carol.
Yeah.
Well, does anyone have any more questions? Because it looks like we've answered all the questions for today. There might be one more. Let's see. Is there a way for us to find out a status of a transfer? Yes. Sarah, you can definitely get in touch with Jeannie Ann Love at UAB, and she handles all the transfers, and you can speak with her, and she can definitely give you a status update. And then I appreciate everyone who joined the call today, and I hope that everyone's finding these monthly user group calls helpful. And then we do have one more question. Is there still going to be a database update in July? There is going to be a database update, but it's not going to be July. It's going to be more in the fall. We had a couple of little delays with COVID, with the COVID-19 and the updates we had to make. So it looks like that the new release will be in the fall. And what we'll do is we'll have webinars we'll offer multiple webinars during different days and times. So everyone will be able to join and we can go over the new additions. But I appreciate everyone that joined the call today. And Carol, is there anything you would like to share?
Well, thanks everybody for joining. Thank you, UAB, and thanks, Catherine. It was a good call.
Thank you, Carol. Thank you, Leanne, for joining. And thank you, Janella.
Sure, thank you.
For helping, and for everyone at UAB that joined, John and Ryan and Jeannie Ann, thank you. And I will get those implant discharge, I'll get those slides out and the infection tip sheets out and email you, Kelly. So thanks, everyone. I hope everyone has a good day.
Thanks, Catherine. You too. Bye, everybody.